All right, let's talk about some of the most common and, let's be honest, most feared injuries in sports. But here's the thing. This isn't going to be based on guesswork or just, what people think. We've actually got our hands on the official playbook that team doctors use, and we're going to walk through it together. You've seen it a million times, right? It's the big game, a key player makes a super sharp cut, and bam, they're on the ground, clutching their knee. Or maybe a pitcher winds up for a fastball, and you just see them wince in pain. In that split second, what's actually the right move? What's going through everyone's head? Well, for the team doctors on the sideline, the answer isn't some gut feeling. It's a system, a protocol that's backed by decades of research and hands-on experience. And today, we're getting a peek inside that exact protocol.
So what is this playbook we're talking about? Where does it come from? Well, it all comes from a single, really powerful source.
See, the guide we're using is what's called a consensus statement. This isn't just one doctor's opinion. It's a document where count 'em, six of the biggest sports medicine organizations in the U.S. all sat down and agreed on the best way to handle these things. So this is what the experts agree on. Let's dive in, and we'll start our tour of the body right at the top.
First up, we're looking at the arm. And not just any arm, but the incredibly complex machine that is the throwing arm. And we're starting with one of the most dramatic injuries you can see on any field or court.
A shoulder dislocation. It's pretty much exactly what it sounds like. The ball of the upper arm bone literally pops out of the socket. It's an acute, sudden injury. There's no mistaking it. But the real story here isn't just about that one single event.
Okay, just look at this number, 92%. That is staggering. The experts found that for young athletes in contact sports, the chance of that same shoulder dislocating again can be as high as 92%. No, that is not a typo. And it really highlights this crucial theme we're going to see again and again, the difference between a single traumatic injury and a chronic recurring problem.
And this lays it out perfectly. It really shows the two sides of the coin. On one side, you've got that acute trauma, right? Like the dislocation, sudden, painful. But on the other side, you've got these overuse injuries, which are often way more subtle and complex, like something the experts call the disabled throwing shoulder.
So here's the key point. Disabled throwing shoulder isn't just a fancy term for a sore shoulder. It's actually a symptom. The problem might show up as pain in the shoulder, yeah, but the cause? The cause could be somewhere else entirely in what's known as the kinetic chain.
Think of a whip. Where does all the power come from? It comes from the handle, right? Not the tip. Well, an athlete's body is exactly the same. The power for a throw starts from the ground, in the legs. It moves up through the core, and only at the very end is it transferred to the arm. So if there's a weak link anywhere in that chain, let's say weak hips or a tight core, the shoulder and elbow have to pick up the slack, and that leads to overload and eventually injury.
All right, so let's follow that kinetic chain down to the legs and knees. This is home to some of the most common and, frankly, most devastating injuries in all of sports.
The dreaded hamstring pull. I mean, if you've played any sport that involves sprinting, you know this one. And this consensus statement pretty much confirms it. It is the king of non-contact muscle injuries. So what puts an athlete at risk for this one?
Well, the single biggest predictor is having had one before. Once you've pulled it, you're much more likely to do it again. Age is also a huge factor. But check out that last point, eccentric strength. What's that? It's your muscle's ability to act like a brake, like when it's lengthening to slow your leg down at the end of a stride. A weakness there is a major, major red flag. And now, the one every athlete fears, the ACL tear. The ACL is a crucial ligament for keeping your knee stable. And the scary part is, it often tears not from some massive hit, but from a simple, explosive movement. A pivot, a cut, a bad landing, and it's gone. Now, listen to this quote, because it's a really sobering one, and it comes directly from the expert's report. The bottom line is, whether you have surgery to fix it or not, the injury itself increases your long-term risk of arthritis in that knee. It fundamentally changes the joint forever.
And this leads to a really, really tough decision for the athlete. If you go the non-surgical route, you're at a higher risk of doing more damage to the knee's shock absorbers, the meniscus. But surgery, while it does stabilize the knee, doesn't get rid of that future arthritis risk. So you can see there's no perfect answer here. That's why a deep, honest conversation between the athlete and their medical team is just absolutely essential.
Okay, let's move on up to the engine of the body, the hips and the groin. This is an area where pain can be incredibly confusing and really, really hard to diagnose.
So, you've probably heard the term sports hernia, right? Well, the doctor's consensus is that this label is often pretty misleading. They tell us to think about groin pain as coming from one of two main places, either the muscles and tendons right around the pubic bone or from deep inside the hip joint itself.
Now, when the pain is coming from inside the joint, the most common culprit is a condition called FAI. Basically, because of the shape of the bones, the ball and socket of the hip joint kind of pinch each other during certain movements. Over time, this can damage the cartilage. But, and this is a really important but, there's a catch.
And this is just so crucial to understand. Just because an X-ray or an MRI shows the bone shape that's associated with FAI, it doesn't automatically mean it's the source of the pain. And it definitely doesn't mean it needs surgery. Tons of high-level athletes have this exact anatomy and are completely pain-free. It's a classic case of treating the person, not just the picture on the screen. So we've toured the body's high-risk zones, from the shoulder down to the knee and back to the hip. But what's the big takeaway here? How do we use all this knowledge to train smarter and hopefully stay a little healthier? Well, the report gives us a pretty clear formula.
First, manage your workload. Your body hates sudden changes, so you got to avoid those big jumps in how hard or how long you're training. Second, build that kinetic chain we talked about. It all connects. Strong hips, a stable core, good eccentric strength, that protects your arms and legs. Third, use programs that are actually proven to work. The experts point to specific exercise programs that basically train your nerves and muscles to work together to control your body safely. And they've been shown to seriously reduce hamstring and ACL injuries. And finally, number 4, you have to respect recovery. You don't get stronger during the workout. You get stronger when your body rebuilds itself afterward. Rest is part of the work.
And that really brings us to our final question. This is the question that every athlete, every coach, every weekend warrior should be asking themselves. Are the hours you're putting in actually making you more robust and resistant to injury? Or are you just rolling the dice every time you train? The experts have handed us the playbook. The final play? Well, that's up to you.